Our next speaker is the team of, it was team 13, but I think they had good luck. Hope Gray, Christian Stackhouse, Richard Kennedy, Wayne Liang, Israel Sign, and Elaine Kofi. Sorry if I badgered the names. COVID-19 disease burden and comorbidities in African American patients at UAB.
Good morning, everyone. I'm Isra Al-Hussein, IBS PhD student at Tuskegee University. Today, we will be presenting a collaborative work done during the hackathon between student and mentor from UAB, University of Maryland, and Tuskegee University. Our topic title is COVID-19 disease burden and comorbidity in African American patient at UAB. The team members are Hope Gray, PhD student at UAB, Dr. Ellen Coffey, assistant scientist at Johns Hopkins University and PhD student at University of Maryland, Christian Stackhouse, PhD student at UAB, and this work done under the supervision of Dr. Richard Kennedy, associate professor at UAB, and Dr. Wayne Liang, assistant professor at UAB. A COVID-19 outbreak is rapidly evolving worldwide, and studies showed that COVID-19 positive patients with any comorbidity have poorer clinical outcomes than those without. And based on the CDC data on the presence or absence of underlying health condition, higher percentage of patients with underlying condition and other risk factors, such as advanced age group or race, were admitted to the hospital and to the ICU than patients without any underlying risk factor. As shown in this graph, out of 7,000 patients, 40% of those were underlying condition with underlying condition were hospitalized, compared to 9% without any underlying condition. Diabetic patients represent about 11%, followed by chronic lung disease and cardiovascular disease. Moreover, the hospitalization rate for COVID-19 increased with age, as shown in this graph, and CDC data showing that the African American and other minority group are disproportionately affected with COVID-19. Here are the data from New York City Department of Health and Mental Hygiene showing that Black African American COVID-19 patients were more affected compared to the other population. Furthermore, African American currently make up 52% of the reported cases in Mississippi and 62% of the reported deaths. Alabama Department of Public Health COVID-19 data reported that Black patients have higher infection and death rate compared to the other population. Since the demographic characteristic and the underlying medical condition and clinical outcome for the hospitalized patient with COVID-19 are needed to inform prevention strategy and community-specific intervention message. And based on the previous data mentioned, our hypothesis was that African American population at UAB Medical Center with positive COVID-19 diagnosis have higher, greater illness and severity compared to the other races. Specifically, we want to identify the disease burden and comorbidity of African American patients at UAB Medical Center compared to the other race. Our study population were a total of 749 COVID-19 positive patients, and African American were about 285 patients out of those. We obtained the data from UAB COVID-19 clinical data ITB2 2020, and then we compare our study population based on the race, age, and gender and comorbidity. And then we divide them based on the disease burden into 5 groups: outpatient, inpatient without ICU, inpatient with ICU, inpatient with ventilation, and disease patient. We use RStudio to complete the data analysis and the statistical approach. Statistical tables, summary table, and regression analysis and box plot were used to represent the data graphically. And now, Christian Stackhouse will present our result, study limitation, and future work. Christian.
All right. Next slide. So On the left is our table of participant characteristics. Again, the total patient size was 749, with 285 of those identifying as Black or African American. And what we noticed was that African American patients were more likely to be admitted to the hospital, and were also more likely to have a higher disease severity score as being admitted to the ICU, being intubated, or actually dying from the disease. On the right top, we show the race and gender breakdown. So the left peak is the Black African Americans, with slightly more females than males. And then on the right, the large peak is the white population. On the bottom is plotted the severity score on the x-axis increasing from left to right. And then on the y-axis, from top to bottom, is the number of comorbidities, with 0 comorbidities at the top and 8 comorbidities at the bottom. And the general trend we see is that the number of comorbidities, as it increases, the severity score also increases. So next slide. So here is plotted the severity score on the x-axis based on age on the y-axis, and it is listed by race, or labeled by race on the left and by sex on the right. And what we notice on the left is that the linear relationship is positive for all races with age, except for the Hispanic Latino group, which actually had an inverse relation between severity score and age. And then on the right, we notice that the female trend is that severity score increases slightly more rapidly with age than for males. Okay, next slide. So on the left here, we show the number of comorbidities, again, which increases from top to bottom. And this is shown by race, with a higher prevalence of multiple comorbidities in African Americans compared to other races. And then on the right, we show that for male African Americans, the average severity score is higher compared to other races, and also compared to female patients. So now we have, based on the odds ratios that were based on the ordinal logistic regression model here, we found that ethnic Hispanic Latino patients are 4.28 times more likely to have a higher severity score. We also found that with each additional comorbidity, the risk of higher severity increases by 49%. And for each year of age, the risk of higher severity increases by 3.5%. And then at the bottom there, we show the linear regression model and the coefficients with the comorbidities. So the highest significance level was for overall number of comorbidities. And then that was followed by sepsis, acute respiratory distress syndrome, hypertension, diabetes, lymphocytopenia, and pneumonia. So these are all comorbidities that have a increased risk of severity. What we found, asthma, bronchitis, flu, obesity, and ventilator-induced pneumonia were not significant predictors of higher severity in patients. So next. So this is showing the pneumonia, patients with pneumonia broken down by race. And what we see is patients with pneumonia have higher severity scores, and the African American patients with pneumonia have a slightly higher average severity score than other races. And then similarly for lymphocytopenia on the right, patients with lymphocytopenia have higher average severity scores, and for African Americans, it's slightly higher than for other races.
You're at 9 minutes.
So our limitations, the first limitation we had was the difficulty in coding for ICU admissions. So patients are often admitted to different departments and then transferred to ICU beds. So that made coding very difficult to parse the data. And then we also had initially planned to look at gene expression data, but there's a lack of genomic, patient host genomic and host expression data for this cohort. And so for future work, we'd like to look at social determinants of health and environmental conditions that would point to why minority groups have a higher prevalence of severe COVID infection. And we also would like to obtain COVID data from other Alabama clinics that see more African American patients, because the UAB patient population is skewed more towards white patients than it is toward African Americans. So we want to capture a more representative cohort by looking at additional information from other clinics. So with that, we list our acknowledgements and thank the hackathon team and organizers, and we'll take questions. Any questions?
Are the results what you expected? Was there anything unexpected?
So we were looking, primarily for comorbidities with African Americans, but what we noticed was actually the ethnic Hispanic Latino seemed to have a poorer outcomes than the African Americans. So it's still a minority group, but we weren't necessarily focused on the Hispanic Latino group.
With the sample size increase, do you expect results to change?
I would expect them to change, just because I know, for instance, Christ Health Center collects a lot more data on African Americans, especially in a more vulnerable population. So I think the UAB data is slightly skewed. So we would need a more representative sample to get more accurate, I think, conclusions.